Oncology Committee of Kasoga. I welcome everybody to today's webinar on Avant-Garde Insights in the Management of Adnexal Masses. I especially welcome Dr. Durgadas Asrana sir, President of Kasoga, Dr. Shobha Gudi ma'am, Secretary General of Kasoga, Dr. Shobha Bembalgi ma'am, Honorable Treasurer of Kasoga, and Dr. Soumya Mani ma'am, EC Member of Southwest Zone, and the Honorable Speakers, Dr. Lohit and Dr. Rupesh sir, and all the participants. Warm welcome to all of you. So before we start off with the webinar, we are introducing certain etiquettes to help us maintain the punctuality of the sessions. So specifically, there will not be any question answer session dedicated in the webinar. It will be done exclusively on the chat. If anybody wants to add certain points to the topic discussed today, they can do so on the chat and they will be answered on the chat itself. The microphone access will be given to the MOC, moderator, and the speakers only. So kindly cooperate with us. This is to keep up the timing slots of the webinar. So let us begin with the first session. The first session is on imaging essentials in suspicious adnexal masses and recent concepts in the imaging reporting for the advanced ovarian cancers. So the first speaker.
Sorry to interrupt. I'm so sorry. Yeah.
Yes, sir. Can we start with the prayer, sir?
Yeah, definitely. So we will start with the prayer. Yeah, since I know a little bit of singing, I will just sing a few lines of Lord Ganesha, and also Ganesh Chaturthi is approaching. गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि. So yeah, let's have a good beginning for this event. And just being the chairperson of the Karnataka State Obstetrics and Gynecology Kasoga Association for the Gynecological Oncology and Preventive Oncology Committee, as already Dr. Prerna has welcomed, warm welcome from my side as well. Just briefly about this particular program. This webinar actually is mainly intended to the practicing gynecologists, wherein we do come across a lot of a plethora of situations when it comes to an adnexal mass. So I always thought that the gynecologist should know, like in terms of course most of them do know, but just that we wanted to know the most cutting edge insights and concepts with regards to imaging as well as managing in terms of be it the early masses or even the advanced cancer. We've included both together. So we will be having imaging to talk about the imaging, Dr. Lohit, who is a senior consultant, and Dr. Prerna will be introducing further. So I hope that this will be a very informative session. And please do send your questions in the chat. And if we are on time and we have finished it on time, we will be more than happy to address every single question verbally as well. Or if we are short of time, we will be definitely answering it on chat. Thank you so much. Go ahead, Dr. Prerna, please.
Thank you, sir. Good evening, all. Dr. Durgadas Asrana sir has just joined the meeting. He is the president of Kasoga. I welcome you warmly on behalf of the Gynec Oncology and Preventive Oncology Committee of Kasoga, sir. Welcome, sir. Over to
Welcome,
sir.
Sir.
Sir would like to address the meeting for a couple of minutes. Over to sir.
Good evening, family of Kasoga. I always call it as family of Kasoga. With respect to Dr. Rupesh, I have seen it from his undergraduate days, which he has done in Tumkur. One of the excellent boy, very academic, very thoughtful person. Today's topic he has chosen adnexal mass, which is essential for all the gynecologists. So many things we may be knowing, but we want to fine-tune our knowledge, and being the specialized in oncology field, Rupesh and associated with Dr. Lohit, who is going to talk about the imaging today. I'm also going to learn a lot from today's webinar. With these few words, thank you for inviting me, and all the best, Dr. Rupesh. Thank you.
Thank you, sir. Thank you so much, sir. Thanks for the
Prerna,
opportunity.
you're doing the good job.
Thank you,
Thank
sir.
you.
Thank you so much, sir. So, moving on to the first topic of today. The speaker for the first topic is Dr. Lohit. He will be speaking on imaging of suspicious adnexal masses and recent concepts in the reporting of advanced ovarian cancers. So, sir is a practicing senior radiologist in Tenet Diagnostics. So, I have come in contact with sir when we were managing our cases. Sir is a huge help in pre-operatively planning our surgeries and helping us to identify the diseases in all the ovarian cancer malignancies for whom we have planned surgeries. So, he has helped us to reduce intra-op surprises, reduce invasive procedures for the patients, and thereby help us to deliver the best optimal care in the management of our patients. Welcome to sir. Over to him to proceed with his topic.
Hello everyone, good evening. Thank you Dr. Prerna for such a warm welcome. Today's topic is an important topic with respect to gynecologists and even the radiologists are concerned. It's most challenging and interesting topic, by the way. Without wasting much time, let's get into the today's topic. I'll be sharing my screen now. Is it visible?
Yes,
Yeah,
sir.
it is.
Yeah.
Make it slideshow, sir.
Yes.
Slideshow might be.
So can I keep it like this so that I can point and show a few things?
Yeah, as long as it's visible
Is
to
it
all the
visible
people.
properly?
Yeah. Yeah, the font size is also fine. I mean, with this font size, definitely yes. If there, I hope that there's no overcrowding, that some lesser fonts will not be seen. But I'm sure that this is what is very much visible to us. So as per your convenience, maybe the right hand pane, whatever you open now, if you can just minimize, so thoda sa the screen will become a little bigger.
Which one second?
I mean, the tiles on the left side and the right side. The right side is whatever, I mean, to your right. Yeah, fine. At least it's a little bigger now. Yes. But I hope you're able to move.
Yes. Can I start, sir?
Please.
Now, coming to imaging essentials in the suspicious adnexal mass and the recent concepts in the radiological reporting for advanced ovarian cancer. When it comes to imaging of an adnexal mass or an ovarian mass, very first line of imaging investigation is an ultrasound, which is followed by an MR, we can use it as a problem solving tool. When it comes to MR, we have a IOTA ultrasound rules for ovarian mass. IOTA is the International Ovarian Tumor Analysis, which was started in 2014. They have made particular rules for an ovarian mass. It's simple set of rules to classify benign and the malignant lesions. And most of 75% of the times you can classify benign to malignant. Out of 25%, it's inconclusive. There are about 5 benign features and 5 malignant features as per the IOTA ultrasound rules. Benign features include unilocular cyst. Second one is the smooth multilocular cyst, which is less than 10 centimeter. Third one is the solid components, which is less than 7 millimeter in diameter. Fourth is the presence of acoustic shadows. and no detectable Doppler signal. Malignant features include irregular solid tumor, irregular multilocular solid mass, which is more than 10 centimeter, more than 4 papillary structures, ascites, and high Doppler signal. When I say high Doppler signal, it has to be color score of 4. I'll come to the color score grading later. Out of these features, if any of the adnexal or ovarian lesion has any one benign feature with no malignant features, then you can name it as a benign lesion. Similar way, if you're seeing one malignant feature with no benign features, then you can name it as a malignant adnexal lesion or ovarian lesion. If you apply these rules, majority, about 75% of the time, you'll be able to characterize an adnexal lesion or ovarian lesion into benign or a malignant. This rules, iota ultrasound rules, does not apply to classic uh, differentials like hemorrhagic cyst, endometriotic cyst, dermoid cyst, because they have a pathognomonic features. So those things are not included in the iota ultrasound rules. So if you apply these rules, sensitivity of this one is about 90% and specificity is about 95%. Next, come to IOTA adnexa model. IOTA adnexa means International Ovarian Tumor Analysis. Adnexa is assessment of a different neoplasm in the adnexa. It's a risk model which is developed by an IOTA group to differentiate benign and a malignant neoplasm of the ovary. It uses 9 different predictors, 3 clinical and 6 sonological features. Out of clinical features, we have age, serum CA-125 levels, and the type of center involved. That's a cancer center or general hospital. When it comes to ultrasound features, you see have maximum diameter of the lesion, proportion of the solid tissue, number of papillary projections, and if the lesion has locules, it has to be more than 10 cystic locules, acoustic shadows, and ascites. Later, ORADS was developed in 2018 by multidisciplinary committee, originally designed for sonographic evaluation, later extended to include MR evaluation in 2020. Now come to ORADS category, ultrasound. ORADS is Ovarian Adnexal Reporting and Data System. It aims to ensure that there are uniform, unambiguous sonographic evaluation of ovarian and other adnexal lesions, accurately assigning each lesion to a risk category of malignancy being present. It's a risk stratification tool designed for accurate characterization of the adnexal lesions and essential for optimal patient management. It's used for risk stratification, like ORADS uses 5 categories, ORADS 1 to 5, 1 being normal and 5 being high risk of malignancy. ORADS 0 is incomplete evaluation due to technical errors. Now let us see the chart of ORADS category. You can see ORADS 0 incomplete due to technical factors, whereas ORADS 1 is a normal or physiological ovary. Coming to ORADS 2, it's almost certainly benign, but it has a risk of malignancy by about less than 1 centimeter. The same way, coming to ORADS 3, it's a low risk. Risk of malignancy is 1 to 10%. ORADS 4 is intermediate risk. Risk of malignancy is about 10 to 50%. And ORADS 5 is high risk with more than or equal to 50% risk of malignancy. This is a chart which is showing a color score, which I was telling in the malignant features of as per the IOTA rules. The first row is that a solid tumor. The second one is a multilocular cystic tumor with smooth margins. You can see the inner smooth margins. The third one is a multilocular cystic lesion with the solid components. When you see the first CS1, first column, CS1 is no flow. There is no flow at all. Whereas CS2, that is color score 2, is a minimal flow. CS3 is a moderate flow, and CS4 is a very strong flow. So CS1 is no flow, whereas CS4 is a very strong flow, which we generally use when we are categorizing the lesion, ovarian or an adnexal lesion, as per the ORADS category. This is a comprehensive chart of ORADS score. As I told you, we'll come to each one by one. ORADS 0, incomplete evaluation. It's again due to technical errors. ORADS 1 is a normal ovary, which includes a follicle, is defined as a simple cyst less than 3 centimeter, or a corpus luteal, which is less than 3 centimeter again. ORATS 2 is almost certainly benign, less than 1% of risk of malignancy, which includes simple cyst or non-simple unilocular cyst with a smooth margin. When I say non-simple unilocular cyst, that means that it has some internal contents, but it's not a solid component, like an internal echoes or incomplete septations. Apart from that, we have a classic benign lesions like endometrioma, we have an hemorrhagic cyst, we have a dermoid cyst, paraovarian cyst, peritoneal inclusion cyst. All these things comes under ORATS 2. That's almost certainly benign. Next, we have ORATS 3 with low risk malignancy. Here we have unilocular cyst, which is equal to or more than 10 centimeter in size, whether it's simple or non-simple. Then you have a typical dermoid, endometriomas, hemorrhagic cyst, but the size has to be more than 10 centimeter. If the size is less than 10 centimeter, it falls into ORATS 2 category. If the size is more than 10 centimeter, then it becomes ORATS 3. Then you have unilocular cyst of any size with irregular inner wall. When we say inner wall, that the thickness of the wall should be less than 3 millimeter height. Then we have multilocular cyst, which is less than 10 centimeter, smooth inner wall, and CS. CS is color score of 1 to 3. And solid lesion with a smooth outer margin, which is of any size, color score of 1. Color score of 1 is no solid, no demonstrable Doppler as such. That means a solid tumor with no vascularity falls into this category, ORATS 3. Now coming to ORATS 4, it's an intermediate risk of 10 to 50% malignancy. We have multilocular cyst with no solid component. Again, in the multilocular cyst with no solid component, it's divided into 3. Any multilocular cyst with no solid component, more than 10 centimeter, smooth inner wall, color score of 1 to 3 comes in this category. Any size, smooth inner wall, but a color score of 4. It becomes ORATS 4 again. Any size, irregular inner wall, irregular septations, or any score becomes ORATS 4. Then you have unilocular cyst with solid component, any size, 0 to 3 papillary projections. I'm saying 0 to 3 papillary projections because you need to count the papillary projections, because if it's 4 or more papillary projections, then it becomes ORATS 5, that means high risk. Then we have multilocular cyst with solid component, any size, color score of 1 to 2. Here also, if the color score becomes 3 to 4, then again it becomes high risk. Then you have solid lesion with a smooth margin, any size, color score of 2 to 3. It's ORATS 4. If the color score is 4, then it becomes high risk. Now coming to ORATS 5, it's a high risk with more than 50% risk of malignancy. We have unilocular cyst, any size, more than 4 papillary projections, color score, any color score. Multilocular cyst with a solid component, any size, color score 3 or 4. Solid, smooth, any size, color score of 4. So if this one becomes color score out of 2 or 3, then it becomes intermediate risk, ORATS 4. Solid, irregular, any size, any color becomes high risk. Then if you're seeing ascites or any peritoneal nodules, then it again becomes ORATS 5. So any lesion, ovarian lesion or an adnexal lesion, which is ORATS 4 or 5, that has to be managed by a gynae-oncologist. Next, coming to, these are the common benign lesions, like typical hemorrhagic cyst. How does hemorrhagic cyst appear on ultrasound? It's like a thin wall cyst with multiple fine reticular pattern or lace-like strands. You can see a retracting clot also. Retracting clot will not be vascular and it will have a concave margins along the periphery. Then dermoid cyst. Dermoid cyst looks like it's a hyperechoic lesion with posterior acoustic shadowing. It can have multiple lines and dots. That's nothing but the hair. And you can have that sack of marbles like echogenic spherical structures, classical of a dermoid cyst. Endometriomas. Endometriomas, thin or a thick-walled cystic lesion with diffuse homogeneous internal echoes or a ground glassing with the posterior acoustic enhancement, not a shadowing. If you're seeing a shadowing, that becomes dermoid. If you're seeing posterior acoustic enhancement, then it becomes an endometriomas. Then paraovarian cyst, you're seeing some simple cyst in the adnexa that separate from the ovary. So you need to see a ovary separately and you see adjacent small cyst, then you can name it as a para-ovarian cyst. You can use a transducer, ultrasound transducer, just by applying pressure and see whether it moves or not to confirm whether it's a para-ovarian cyst or something else. Peritoneal inclusion cyst. Peritoneal inclusion cyst usually follows the contour of the adjacent pelvic organs. It does not exert any mass effect. They typically have a septations. You can see a ovary suspended within the lesion or at the margin. Then you have hydrosalpinx. Hydrosalpinx is a thin tubular cystic structure with incomplete septations. You can see that endosalpingeal folds. Ovary should be seen separately. Then you can name it as a hydrosalpinx. Let's come to each ORADS with the images examples. So this is coming to ORADS 1. The first image is the follicle. You can see thin follicle, smooth anechoic with no septations clear. It's a unilocular cyst. So it's normal ovary. Or else you can see a corpus luteal cyst which is less than 3 centimeter. Corpus luteal cyst, the wall will be thickened. Can you make out here? The wall is thickened. This is the thickness of the wall. And you have that granulated inner margins. When you put a Doppler, there's an intense vascularity around the corpus luteum. Or you can just look it can appear as a hypoechoic lesion with intense vascularity along the margin, as we see in a third image. See, these are the few examples of a corpus luteal cyst, where in the first image you can see thick-walled cystic lesion with intense peripheral vascularity. In the second image, you can see irregular thick-walled cystic lesion with the granulated margins. And the third one, it's a clear cyst with the intense peripheral vascularity. Again, this is also corpus luteal cyst. And we need to measure the size of the cyst basically. In the fourth image, lower down, you can see the cystic lesion and you can see some part of a solid component in its upper part, but it's not showing vascularity. You can see the vascularity only along the margin. Here you can say it's a corpus luteal cyst confidently. These last two images are hypoechoic lesions, but only when you put a Doppler, you can see increased vascularity. That's when you differentiate a corpus luteal cyst from any other solid lesions. Now coming to ORADS 2, here we have a classic benign lesions with the image examples. As I told you, hemorrhagic cyst. You can see the thin wall cyst with multiple lace-like septations. This is a retractile clot. Can you see the concave margins? Peripheral vascularity. Dermoid cyst is echogenic lesion within the complex cyst. This is a posterior acoustic shadowing. That's a dirty shadowing. I mean to say, it appears dark beneath the echogenic lesion. It's a classical of a dermoid cyst. And this is a sack of marbles, small spiracles around the cystic lesion, within the cystic lesion. This is a dermoid cyst. Endometrioma is classic. It's like a diffuse, homogeneous internal echoes with a posterior acoustic enhancement. This is how the endometriomas appear. Para-ovarian cyst, thin wall cyst, which is separate from the ovary. You can see the ovary separately here. It's just abutting the ovary. This is a para-ovarian cyst. This is a peritoneal inclusion cyst. You can see all these endosalpingeal folds. It's not causing any mass effect. You can see the second image where ovary is suspended within the cystic lesion, whereas in the fourth lesion, you can see periphery, ovary along the margin basically. And the last one is a hydrosalpinx. It's a thin wall cyst. You can see these are all incomplete septations. These are all incomplete septations. So thin wall cyst with incomplete septations. And you can see a ovary separate from the cystic lesion. That's an hydrosalpinx. Now coming to the
sorry to interrupt. Is it possible to make this a slideshow? Because slightly, if the images are a little bigger, it will be even more interesting, if possible.
One sec, sir. Is it fine, sir?
Yeah, it's better.
Is it fine now?
It is better now.
It is better.
Okay, fine. Yeah, ORADS 2 almost certainly benign, less than 1% likelihood of malignancy. We have a simple cyst here. clear cyst, no internal echoes, no papillary projections. In ORATS 2, you have this all classic benign lesions. As I told you, all those hemorrhagic cyst, endometriotic cyst, dermoid cyst, para-ovarian cyst, or even hydrosalpinx. But these lesions should be less than 10 centimeter in size. Then it falls in ORATS 2 category. If it's more than 10 centimeter, then it falls to ORATS 3. When I'm talking about non-simple unilocular cyst with a smooth inner margin less than 10 centimeter, this is the example. You can see that there are internal echoes within, but no vascularity, and you can see that incomplete septation. This should not be confused with the papillary projections. This is a non-simple unilocular cyst. Again, this is a comes to ORATS 2. Okay, these are the classic images of hemorrhagic cyst. You can see mildly thick wall cyst with multiple septations, lace-like septations. Here also you can see lace-like septations. These are all retractile clot, basically the concave margins along the periphery. Even in this image C also it's like an hemorrhagic cyst. You can see the arrow marks. These are retractile clot. Image D, this again asterisk is a retractile clot. You can see peripheral increased vascularity in the image E with the retractile clot in the center. There's no vascularity within the solid component. It's a classical of hemorrhagic cyst. This is a dermoid cyst, complex cystic lesion with the echogenic content within. And this is, I called a posterior acoustic shadowing. It should be dirty shadowing. I mean, it appears dark. Echogenic component within the complex cystic lesion. That's basically fat, and then multiple linear structures within the lesion. This nothing but a tuft of air. In the third image, you have this fluid level and echogenic lesion all on the periphery. It's a fat globule, basically. It's classical of a dermoid cyst. And the fourth image, again, it's a bright echogenic component within the lesion with multiple fine reticulations. It's a tuft of hair. And the last one is like classical sack of marbles, multiple spirals of within the complex cystic lesion. This is dermoid cyst. These are the examples of endometriomas. You can see smooth wall, diffuse internal echoes, ground glassing kind of a lesion with no vascularity. Only you can see the peripheral vascularity, not within the lesion per se. And you should not be confused with the complex lesion by looking at the septation in the fourth image. This vascularity, it's basically multi-septated endometriotic cyst or endometriomas. And you can see tiny echogenic foci along the wall. When you put a Doppler, it's not a vascularity. In the last image, whatever I'm showing, it's a twinkle artifact. It's a basically ultrasound artifact. They should not be confused with the vascularity within the lesion. So it's a twinkle artifact. Now coming to ORATS 3, which has a low risk, 1 to 10% likelihood of malignancy. You have a unilocular cyst, which is more than 10 centimeter, as I told you. And typical hemorrhagic cyst or dermoid cyst or endometrioma, which are more than 10 centimeter. If it's less than 10 centimeter, it becomes ORATS 2. Then you have unilocular cyst with irregular inner wall of any size. That wall, when I say, it has to be less than 3 millimeter height. Then multilocular cyst with a smooth inner margin, which has less than 10 centimeter, and a color score of 1 to 3. That means no flow to moderate flow. The last one is a solid or a solid appearing lesion with a smooth contour, any size, color score 1. That means no color flow. When I say solid appearing, that means in a lesion, adnexal or ovarian lesion, at least 80% of the lesion should have a solid component. That's when you call solid appearing. If it's a complete solid, yeah, then you're not seeing any cystic component within it. These are the coming to ORATS 4. It's an intermediate risk, 10 to 50% likelihood of malignancy. You have a multilocular cyst with a smooth inner margins, which are more than 10 centimeter in size, color score of 1 to 3. It's no flow to moderate flow. Then multilocular cyst with a smooth inner wall, any size, color score of 4. that means a very strong flow. It becomes 4. If the color score is 1 to 3 here, then it becomes ORATS 3. Then you have multilocular cyst with irregular inner wall and irregular septations, any size, any color. ORATS 4. Unilocular cyst with the solid appearing or solid component, no papillary projections, any size, any color, becomes ORATS 4. This is the unilocular cyst with 1 to 3 papillary projections. You need to count the papillary projections whenever seeing unilocular cyst, and you need to check on the vascularity within the papillary projections. If you're seeing 1 to 3 papillary projections, any color score, whether there is no color also, I mean, it falls into ORATS 4. If there are more than 4 papillary projections, then it becomes ORATS 5. Multilocular cyst with a solid appearing component, any size, with the color score of 1 to 2. Then solid or solid appearing lesion with a smooth contour, any size, color score of 2 to 3. Falls into ORATS 4 category. See, here the color score is very important to differentiate, like from no flow to very strong flow. Sometimes it's very subjective. This is where the MR plays a role. Now coming to ORATS 5, it's a high risk lesions, more than 50% likelihood of malignancies. We have unilocular cyst with more than or equal to 4 papillary projections, any size or any color. We have a multilocular cyst with solid component, any size, color score of 3 to 4. That is moderate to very strong flow. Solid lesion with a smooth contour, any size, but color score has to be 4. It's not, if less than 4 color score, then it becomes ORATS 4. Solid or solid appearing lesions with irregular contour, any size, any color, is ORATS 5 lesion. And if you're seeing ascites or peritoneal nodules or peritoneal thickening, then it becomes ORATS 5 lesion. So this is a risk stratification categories. I mean, this graph to show how to go about it. Like if you're seeing any cyst on ultrasound, first you need to measure the cyst and see the contents. It's a solid or cystic. So if it's visual, if it's less than 3 centimeter, you can take it as a follicle or a corpus luteal cyst. Then you need to keep in mind about the classic benign lesions. When you're saying benign lesions, you need to see whether it's arising from the ovary or it's extra ovarian. When you are seeing an ovarian lesion, only 3 you can think of: hemorrhagic cyst, dermoid cyst, and endometrioma. If you're seeing extra ovarian, then you can think of para-ovarian cyst, hydrosalpinx, and peritoneal inclusion cyst. Not classic benign lesions. Here we need to see whether it's a solid lesion or a solid cystic lesion. If it's a solid lesion, you need to look at the outer contour. If it's irregular outer contour, then you put a color and see, then it becomes ORATS 5. If it's a smooth, then you see this color score, whether it's 1 to 2 or 3 to 4. Depending on that, you can characterize into ORATS 4 lesion or 5 lesion. If you're seeing a cystic lesion, you need to see whether it's a unilocular cyst or a multilocular cyst. If it's a unilocular cyst and you're seeing a solid component, you count the number of papillary projections. If it's less than 3, ORATS 4, more than 4 or equal to 4, ORATS 5. No solid component, then you need to see the inner wall, whether the inner wall is smooth or irregular. By looking at the inner wall, then you see the content size. Based on that, you can further characterize into ORATS 3 or 4 or 5 lesions. If it's a multilocular cyst, multilocular cyst with a solid component, do the color score, characterize into ORATS 4 or ORATS 5. Multilocular cyst with no solid component, look at the inner walls and the septations. If it's irregular, then again look at the color and characterize into ORATS 4 or 5. The same way you look at the inner walls, smooth, or then you see the size and the vascularity, I mean the color score. Depending on that, you can characterize it to ORATS 4 or 5 lesions. This is basically simple chart to characterize, I mean, how to go about it, if you're seeing an adnexal ovarian lesion, how to go about it. Now coming to ORATS MRI risk stratification and management system. See, as I told you, ultrasound has its own limitations, like in counting the papillary projections or even measuring the inner wall. Say, as I told, less than 3 mm is important. So 3 mm is such a narrow margin. So there are some errors there when you're doing an ultrasound in counting the papillary projections or inner wall, and especially the color score. If I may feel the color score of 3, or some other readers may feel that color score of 4 or a 2. So this is where the MR comes into picture. Since we have a multiple sequences in MRI like T1, T2, GRE, diffusion weighted imaging, and we do contrast study. That's how MR can be useful in, especially MR is useful in inconclusive or intermediate lesions. Like when, as I told you in IOTA rules, there are about 25% of the lesions which are inconclusive. That's where MR plays a role. And it allows a accurate characterization of both fluid and solid components of the adnexal lesion. So if you're seeing a fluid, you can mention whether it's a clear fluid, or it's like hemorrhagic fluid, or it's a proteinaceous or a mucinous content within the lesion by looking at the different MR sequences. The presence of a solid tissue with a high risk enhancement curve has a positive predictive value of cancer for approximately about 90%. The same way, absence of enhancement has a negative predictive value of about 98%. Even when you are doing a dynamic imaging study of adnexal lesion in MRI, we do see the enhancement pattern of the lesion per se. That enhancement pattern has to be compared with the myometrium, basically. If the patient has undergone a hysterectomy, then you can compare the enhancement pattern to the adjacent muscle, any muscle. In the enhancement, MRI enhancement pattern, we have three type of curves, like low risk curve, intermediate risk curve, and high risk curve. Low risk curve, in the sense like when you do a dynamic study, we'll be taking multiple sequences. In the low risk curve, the lesion, the solid component of the lesion, enhances slowly and smoothly, relatively less than the myometrium. It does not have a plateau. I mean to say, the enhancement won't plateau. Whereas in an intermediate risk curve, the enhancement is intense, but it has a plateau after some time. I mean to say, in the fourth sequence or a fifth sequence of a dynamic study. But the enhancement, whatever you're seeing in the solid component in an intermediate risk curve, should be less than or equal to the enhancement of the normal myometrium or adjacent muscle. In a high risk curve, this earlier enhancement will be more than that of a myometrium, and it has a plateau after the third or fourth phase of a dynamic study. So intermediate risk curve, it's a ORATS 4 lesion. High risk curve, ORATS 5 lesion. Low risk curve, probably almost certainly benign lesion. Okay. Now, apart from this, this is with respect to the MR risk stratification is concerned. With respect to the ORATS category, it's almost the same. Only thing is, we are seeing the papillary projections and the solid components and the septations and enhancement in a better way compared to the ultrasound per se. And MR will be useful in like benign lesions. Like we do a particular sequence called T2 weighted imaging, where if you're seeing a T2 hypointense signal lesion, adnexal lesion on MRI, then that's benign. Probably like all these thecomas, fibrothecomas, even per se like broad ligament fibroid. So I mean, this one you cannot differentiate on an ultrasound. This is where MR plays a major role. Now going to the next topic, recent concepts in the radiological reporting for advanced ovarian cancer. Majority, about 80% of the ovarian cancer patients present at advanced stage. Imaging performed on these patients will have numerous findings. Epithelial ovarian cancer is the most common histological types, accounts for about 90% of them. Most of the epithelial ovarian cancer, among the epithelial ovarian cancer, high-grade serous carcinoma, which is account for 70 to 80%, and they present at a later stage actually. Coming to imaging of for staging of ovarian cancer, CECT, that is contrast enhanced CT, is the primary modality of choice for staging ovarian cancer with about 90% accuracy for staging. Recommended imaging protocol is a CECT of thorax, abdomen, and pelvis. It has to be triphasic CT. Triphasic in the sense like we have to do plain CT, arterial, venous, and a delayed. Then MR with contrast is more appropriate as a problem solving tool, but it has its own limitation like a cost factor or patient compliance, and it's very difficult to see the lesions which are less than 1 centimeter because of bowel movements, especially peritoneal lesions or omental deposits. And even when you're doing an MR abdomen pelvis, you need to have a 2 coils, MR coils. Then only we can paste the images from abdomen till the pelvis. Otherwise, you'll have to see separately. In between, you may miss certain findings. I mean, especially see when you're looking at a ovarian cancer staging, you need to see minute of the minute things, like even the millimeter in millimeter. So those things can be missed on MRI. That's why generally we prefer CECT as a modality of choice. FDG PET-CT is not recommended as a primary staging modality because all ovarian cancer are not FDG avid, and PET-CT is less sensitive for identifying peritoneal nodules which are less than 1 centimeter, or even a small bowel serosal or a mesenteric disease. Structured reporting format. See, first we need whenever we do a CT, first we have to see whether are we dealing with a primary ovarian cancer. Is it the lesion is arising from ovary or something else? And you see like omental deposits or peritoneal nodules, that can be seen in like other conditions also, like peritoneal carcinomatosis, even Cox abdomen, TV abdomen. So first we need to make sure whether you're dealing with the primary ovarian cancer or metastasis. If ovarian, then we need to see tell what is the FIGO staging. Then we need to answer whether it's a complete or a optimal cytoreductive surgery can be done. If being planned for a neoadjuvant chemotherapy and interval debulking, what are the best suggested site in a modality for image-guided biopsy? Always you should avoid biopsy of early malignancies. Chances of spillage is high, and metastasis spreads, and even ascites. If you need a tissue diagnosis, yeah, definitely we can go ahead with the biopsy and do it as per the gynae oncologist request. We have a thing called peritoneal cancer index or carcinomatous index. It's a surgical index designed to estimate the tumor burden in the peritoneal cavity. What we do is it's basically sum of scores given to the peritoneal disease based on its size in 13 different sites within the peritoneal cavity, with a potential score ranging from 0 to 39. PCI of more than 13 was found to predict a suboptimal cytoreduction. When we are scoring the PCI, we have 3 scores, which I mean, like score 1 is lesion less than 0.5 centimeter. Score 2 is lesion between 0.5 to 5 centimeters. Score 3 is more than 5 centimeter or a confluent disease. Mesenteric disease and a small bowel serosal disease, the sign of advanced disease. Identifying these features on imaging is very important to prevent attempts to perform cytoreductive surgery, since this will result in a suboptimal debulking. Sensitivity of MDCT is only 65.5% for nodules less than 1 centimeter, and there are chances we miss miliary metastasis. This is the thing which I was telling about peritoneal cancer index. I'll just go to the, yeah. This is a peritoneal cancer index. So this is how we measure. Central abdomen is 0, and the right upper is 1, 2 is epigastrium, 3 is left upper, 4 is left flank, 5 is left lower, 6 is pelvis, 7 is right lower, 8 is right flank, 9 is disease along the upper jejunum, 10 is along the lower jejunum, 11 is along the upper ileum, and 12 is along the lower ileum. When we are seeing lesions, when you're seeing lesions in the pelvis, that's 6, we should not include the ovarian lesions. You should only include the adjacent to the ovarian lesions, whatever you're seeing the deposits. Lesion size score is the same as I told you: 0, no tumor; 1 is tumors up to 0.5 centimeters; 2 is tumors up to 5 centimeters; 3 is tumors greater than 5 centimeters. So we need to calculate in each quadrant and sum up and see how much the peritoneal cancer index. This is a standard structured reporting template for an ovarian cancer. As I told you, first ovarian mass, you need to see whether you need to tell whether it's a ovarian mass or something else. If it's a ovarian mass, you need to say whether it's a unilateral or bilateral, and what kind of ovarian mass is a solid cystic or predominantly cystic. And we need to comment on the margins. So it's a irregular margin, papillary projections, is it lobulated surface of the lesion, is there any calcifications. I need to comment on the adjacent structures like uterus, rectum, sigmoid colon, and the distal ureter. Is just abutting, or is there a loss of fat plane between the mass lesion and these structures, or is it really infiltrating?
Sorry to interrupt, Dr. Lohit. The thing is, in this advanced may,
Uh-huh.
if we can just highlight, these are the basic stuff. Definitely, all the radiologists will tell. But what is it that they are missing it out? I mean to say, the per se, because generally we see that only presence of ascites is given and omental fat stranding. This is all
Okay,
what they give, and
yeah.
peritoneal. So if you can just tell the important things in this standard international grid, which tells us. So if you can highlight
Yes, sir.
that. And in the context of time also, I'm sorry to interrupt.
Yeah,
Yeah,
yeah.
please
Sorry,
tell.
sorry, sir. Yeah. Now, these are the unfavorable sites of involvement. These are the sites which are generally missed. Thick like plaque along the subdiaphragmatic disease. You need to say is there or not. And disease along the intersegmental fissures. That's I mean to say the falciform ligament, the porta, gallbladder fossa, lesser omentum. And is there any disease encasing the stomach or a left gastric artery? Is there a bowel obstruction? You need to see the root of mesentery, small bowel mesentery, and is there any hydronephrosis? And we need to comment on the pelvic side wall infiltration. Any mass lesion which is less than 3 millimeter from the pelvic side wall, we can call it as an infiltration. Iliac vessel encasement. If there is an encasement by more than 180-degree, then you can call it an encase. Particular vessel is encased. Now, then lymph node metastasis. You need to comment on the nodes with the inguinal, cardiophrenic, celiac, axillary, mediastinal, supraclavicular. Look at the umbilicus for umbilical metastasis. And comment on the pleural effusion, liver, spleen, and lung, brain metastasis. Parenchymal metastasis is different from a surface metastasis because surface metastasis again Figo staging will become 3A or B. If it's a parenchymal, again it goes to 4B. Then you need to look at the any other primers in stomach, colon, appendix, or gallbladder, or pancreas. So finally, you should give a Figo staging. This is just an overview of these are the things which needs to be covered in a proper structured reporting template of advanced ovarian cancer. I think definitely this will help a gynae oncologist to plan their disease surgery properly based on this report. Thank you, sir.
Thank you so much, Dr. Lohit. I'm sure that every single listener, including me, there were so many aspects that we did not know, or rather, we didn't know that there is so much of a precision, or there's so much of depth is involved that has to be looked for in reporting, and that is exactly why I planned for this session, wherein the most important thing is wherein we realize that just going through a report, because in a busy gynecologist practice, it so happens that they just write ultrasound abdomen pelvis or MRI pelvis. So this is what they write. Sometimes, because they're busy practice, and they have so many patients lined up. So, but and reporting also the same thing happens. Like the radiologist may, yeah, they just write, okay, this lesion is present, and this is all it is, like its relation to uterus, push that side, very basic things, but there is so much more into it that I'm sure that after your talk, our gynecologists, especially those who rely on radiologists for their reporting, as well as those who also do reporting by themselves, will definitely find this very enlightening, and would impeccably add on to their practice. Thank you so much for this. I'm sure, like, if there are any questions, you can please text, or because we will also have to start another talk. So kindly text, and we will definitely, if we are on time according to our society guidelines, so we will definitely answer to you in person. That is, we can unmute and we can talk, or else we will definitely get back to you with the thing. And I'm sure we will be sending the YouTube link also to all those people who have signed in, so that if somebody have missed, they can also have it, because I'm sure that there has been umpty number of information that's been given by Dr. Lohit. Thanks again, Dr. Lohit. And yeah, in the context of time, we will go ahead.
Uh, Thank you, sir. I'll just add on one more thing to it regarding diffusion kurtosis imaging in with respect to MRI is concerned. See, basically, diffusion kurtosis imaging is same like a diffusion weighted imaging. Only thing is, when we do a diffusion weighted imaging, we take a B score in a diffusion. That's basically parameter in the diffusion weighted image. Generally, when we do a diffusion weighted imaging, we do only a 0, 500, and 1000. Whereas in diffusion kurtosis imaging, we can go up to 2500. So that will definitely help in the characterization of like a suspicious lesion, solid, especially in solid components. If the lesion is showing the restricted diffusion, then you can say it's like definitely a ORADS4 or a 5 lesion. It's not only the diffusion, you need to see one more sequence called ADC, apparent diffusion coefficient, ADC mapping. The whatever the bright thing you're seeing on a diffusion, that has to look dark on a ADC. Then only you can call it a true restricted diffusion, or else it's not a true restricted diffusion. It's just a facilitated diffusion.
Thank you so much. That was a very, very insightful aspect in terms of diffusion weighted imaging, because I'm sure that nowadays everybody is off late getting to know about the importance of diffusion weighted imaging. So great. So yeah, without wasting much time, I'm going to start. Prerna, you can just go ahead with the.
Sure, sir. Thank you, Dr. Lohit. This speech was insightful in terms of how to order investigations, in whom, which investigations to order, what features to look for, and how to plan the management. Thank you so much, sir. Anybody who has any more queries or anything to add to the topic, can please post it on the chat, and we will be happy to answer the questions. So let's move on to the next topic. The next topic is management of ovarian masses and recent advances in the management of advanced ovarian cancer. The speaker will be Dr. Rupesh, sir. Sir's name is familiar to everyone. He's a senior practicing gynec-oncologist in many major hospitals in Bengaluru. And he is especially trained in peritoneal service oncology from many European countries. Without further ado, I'm handing over to Sir for his topic.
Thank you so much, Dr. Prerna. Mr. Arun, I will be obliged if you can please start the. Yeah, thank you so much. I'm sorry that I have quite a long slides, but I'm sure we will be going at. Dr. Lohit has already mentioned about a few aspects about ovarian cancer. So I'll just run through many slides fast. So next slide, please. As all of us know, adnexal masses are nothing but masses of either the ovary, the fallopian tube, or surrounding tissues adjacent to the uterus. They are commonly encountered by the obstetrician gynecologists and often present diagnostic and management dilemmas. Many a times, we don't know, there's an adnexal mass. We don't know if it's a pedunculated fibroid, or like it's just an ovarian mass, or hydrosalpinx. So many things. So we'll come to the DDs again. So most adnexal masses are detected incidentally on physical examination or at the time of pelvic imaging. So generally, patient may not have any symptoms unless and until it's like kind of too big or like pressing and causing pressure symptoms. But most of them are incidental findings. So less commonly, a mass may present with symptoms of acute or intermittent pain. Management decisions often are influenced by age and family history of the patient. So these are very important, like our decisions, like in terms of like surgical, non-surgical, it's all guided by like how old she is, fertility aspects, as well as the family history. And although most adnexal masses are benign, the main goal of the diagnostic evaluation is to exclude malignancy. That's very important. Next slide, please. So ovarian cancer, as all of us know, just briefly about ovarian cancer, is the most lethal disease of the female reproductive tract. The risk of ovarian malignancy increases with age and decreases with pregnancy. The lifetime risk of developing ovarian cancer is about 1.7%, whereas women with affected first-degree relatives, the risk ups to about 5%, and those with a mutated BRCA or BRCA2 gene mutation themselves, the risk is about 10 to 40%. and those with Lynch syndrome have about 5 to 10% risk of developing ovarian cancers themselves. So as we all know that the 5-year survival, of course, this is a modest number which is now there, but earlier it used to be even lesser, like about 35 to 40%. But now we say like overall 45 to 50%. Yeah, next slide, please. Median age diagnosis of ovarian cancer is 60 years, 70 to 75%, as Dr. Lohit already said, that present in advanced stage, that is stage 3 to 4. But we all know, as gynecologists, we all know that germ cell tumors, sex-cord stromal tumors are the ones, and even the borderline varieties are the ones which present relatively at earlier ages rather than advanced ages. So, of course, germ cell tumors are very exclusively in the younger population, and nearly 10 to 15% of tumors in premenopausal age group are malignant, and most of the complex ovarian cysts after menopause are malignant. Next slide, please. So risk factors, as all of us know, elderly age, nulligravidity, history of infertility, early age at menarche, later ages at natural menopause, use of menopausal estrogens, family history, yeah, suspicious. I mean, sorry, also use of talc and infertility drugs, which I've debated. But still, these are all the various risk factors. Next slide, please. Of course, they say for mucinous tumors, even smoking and women of Asian descent are more prone. The protective factors being opposite of those things like parity, use of OCPs, tubal ligation, hysterectomy, and breastfeeding, which are protective. Next slide. So common symptomatology is all of us know. See, again, we are talking, when we talk only about adnexal masses, they may not be symptomatic at all, but we always have to evaluate it. Like, we have to ask these questions, the negative history, whether they have bloating, they can have early satiety or difficulty eating. Of course, when they have it, they will come to us with those symptoms. But otherwise, like we will, especially in advanced, we will have to ask. So yeah, they also, in advanced cancers, they may also present with early satiety, difficult eating, abdominal distension, GI symptoms. Generally, it's the GI symptoms with which the advanced ovarian cancer patients come to us, like dyspepsia, constipation, nausea, vomiting at times, abdominal pain, urinary frequency, which may be there in earlier tumors also, earlier cancers also, and constitutional symptoms again in advanced cancer, and sometimes granulosa cell tumors and sex-cord stromal tumors also, or even heavy, like huge tumors also sometimes because of the pelvic congestion can cause about sometimes menstrual irregularities and sometimes dyspareunia as well. Next slide, please. DDs, we all know, chronic ectopic, pedunculated fibroid, hydrosalpinx, TIVO-mass, inclusion cysts, chocolate cysts, fallopian tube carcinoma, sometimes fallopian tube cancer, appendiceal tumor, and pelvic kidney. These are the various DDs which we all know by our GYN textbooks. Next slide, please. So management, important is, of course, we all know that the most important thing, three things are: one is clinical evaluation, obtaining tumor markers and imaging. These are the three pillars of our thing. Of course, clinical evaluation, again, is mainly to rule out any advanced disease, wherein we, not just the adnexal mass is palpated, but we also look for other things. Always remember that apart from a speculum and a vaginal examination, whenever we find an adnexal mass, I mean, when they have come with a report to you, or like when you did an incidental finding and you said, also include a rectal examination and look for, like, if there's any parametrial induration or like nodularity of the pouch of Douglas, or tenderness sometimes, and also feel for the rectal mucosa. I'm sure, like, you all know about it, but it's good to include that in our practice. And of course, tumor markers and imaging. Imaging, I'm not going to speak anything because everything has been covered by Dr. Lohit. I will be briefly speaking about tumor markers as well. And of course, doing the other tests like CBC, LFTs, and, rarely we also may have to do upper GI scopy or a colonoscopy when required, based on the, again, based on the tumor markers, if they are elevated. For example, we do one more thing about tumor markers, which I'll be speaking a little while. We always have to, especially since imaging comes first, most of the times, like they come with a scanning in today's world, based on those characteristics, after having characterized whichever ORADS category it belongs into, and, especially, when such a beautiful categorization is given, we tend to know whether the tumor is neoplastic or not. But at the same time, sometimes it is also kind of pointing, the radiologist can point towards the histology. But the radiologist should never mention, if I'm sure Dr. Lohit also will agree with me, that the radiologist should never mention the histological diagnosis. They can only say that it's a neoplastic mass, probably suspicious of malignancy or highly suspicious of malignancy. So this is how they have got to tell. So I'm sure, like, yeah, with that, we will also have a pointer. Like if it's say mucinous and stuff like that, we will also do other markers like CE and things like that. So the important thing is, it's not great to ask all the tumor markers because that adds to the cost. So anyway, so once we have all these things, we also decide if we have to do an upper scope, upper GI scopy or a colonoscopy. And finally, especially for advanced cancers, we also do an MDT, multidisciplinary tumor board, to decide on whether we got to do an upfront surgery or an upfront chemotherapy followed by surgery. So that's, I'll be speaking about advanced cancers later. But yes, for early masses, there isn't much ambiguity. When we have ruled out that it's an early one, we are going into the surgery. But yes, for advanced, we will have to. Next slide, please. So coming to tumor markers, next slide. We all know that the most important thing is CA-125, which is expressed from the coelomic epithelium. So we know that any kind of peritoneal irritation, like it may be a pelvic inflammatory disease or endometriosis, where there's an inflammation of the peritoneum, and even premenstrual, where there is pelvic congestion, huge fibroids, wherein there's a stretching of the peritoneum and congestion again. So because of all these things, the coelomic epithelium will produce CA-125, and that's the reason CA-125 is falsely elevated. I mean to say it is elevated, of course, in these conditions, but it's important for us to correlate it appropriately. So we all know that 35 units is the cutoff limit. But if you see in 85% of epithelial ovarian cancers, it is noted. But in stage 1 disease, it's elevated CA-125 seen only in 50% of cases. I recently operated on a lady who's she had a mass, but stage 1 mass, but her CA-125 has been normal. We keep encountering quite a lot of times when CA-125 is normal. So the sensitivity is low in stage 1 disease, but in advanced disease, it has a very high sensitivity. And of course, poor sensitivity, as we all know, is attributed because of elevations in non-malignant conditions as well. So high false positive rates associated with other benign conditions and malignancies. Sometimes even in other malignancies, also it can be elevated. Anyways, so the sensitivity is improved when it is used in combination with other parameters such as good ultrasound, and of course with menopausal status, age-related incidence of epithelial ovarian cancers, which I'll be speaking about. That is a ROCA, Roma, and all those stuff. So that's when the sensitivity improves. The last patient whom I told, the CA-125 was normal. When we did a HE4, combined with this and a Roma, yes, it was elevated. So that was kind of a predictor. Next slide, please. So yeah, there are various markers, but I wouldn't be going too much into it. Like in clinical practice, what we are doing, the first row, if you can have a look at it, CA-125 is the main marker when combined with menopausal status and ultrasound. Of course, we do an RMI. It used to be a standard practice among gynecologists. But yes, the sensitivity is not so great, but still not so bad. So it is somewhere around 71 to 85%. But with the advent of today's MRI and good ultrasound report, as Dr. Lohit has enlightened us today, we don't have to resort to RMI and stuff like that, because we have wonderful information given by the modern day imaging. But as well, in low resource settings wherein we do not have an MRI, or the basic ultrasound is there, definitely RMI can help in terms of referral to a GYN oncologist. And specificity is high in RMI, as you see. CA-125 levels, the advantage is that it's a prognostic indicator post-surgery, and also during chemotherapy, to look for what is the fall in the CA-125. And it gives us an indicator of the response to therapy, wherein we do serial CA-125. And monitoring disease and recurrence, CA-125 detects recurrence with a sensitivity of about 84 to 94%, which is very important. So all patients who have been treated and cured of ovarian cancer, follow-ups when we are there, every 3 months, once first 2 years, we keep them calling them. And that's when we do not just an ultrasound, as well as we also do a CA-125 clinical examination to see if the CA-125 is elevating or like started the trend, upward trend. It means that there is a chance of recurrence, that she is recurring inside. So there are many other markers which I wouldn't want to tell, like inhibins, kallikreins, mesothelin, prostatin, osteoponin, etc. A lot of things are there. these are also CASA. Many of them are there, but these are all like predominantly under study, and nothing as of now has gone beyond CA125 as the defining marker. But of course, yes, we calculate other things like in early tumors, especially Roma and ROCA, which I'll be talking now. So one more thing about CA125, which I've not mentioned in my slide, is that for in advanced ovarian cancer, we also do something called a Skellim scoring. That is basically an online kind of a formula wherein it tells us about the platinum resistance, the chemotherapy sensitivity of the tumor. Wouldn't speak much about it. Next slide, please. So ROCA is a risk of ovarian cancer algorithm, which is based on age-specific risk of epithelial ovarian cancer plus behavior of CA125 at time. So there were the United Kingdom collaborative trial on ovarian cancer screening. The UKC talks about the famous study which incorporated about 2 lakh women, along with other studies, screening studies like the PLCO and the UK Fox study. They all were the large series screening trials which were done on the general population and women with familial history. So if you see the main study, the UKC talks did not show any kind of major difference between, or it didn't show that there's a significant advantage of screening women in for ovarian cancer. Although the mortality reduction was not significant in the primary analysis, there was noted a significant mortality reduction with multimodal screening when prevalent cases were excluded. So the study also noted encouraging evidence of mortality reduction in 7 years, 7 to 14, but further follow-up is needed before conclusions were made, was what the trial said. So basically, UKC talks told that there's a significant reduction in mortality. There was a mortality reduction benefit, but again, needs to be collaborated. So hence, we don't have a set screening for ovarian cancer is what I would like to emphasize. Next slide, please. And yeah, coming to RMI, we've already spoken, is the multiplying the menopausal status with the ultrasound scoring and the CA125, that gives us the RMI. There are, as I told you, in low resource settings, it's a decent one. Next slide, please. Next slide, please. Yeah. So, yeah. So there are various cutoffs like RMI1, RMI2, and stuff like that. So wherein the cutoff was 200, the standard cutoff was 200, wherein M is 1 if she's premenopausal, M becomes 3 if she's postmenopausal. If there are no features, the U score is 0. If even one feature is there, U is 1, and if there are 2 or more features, the U is 3, and yeah, so this was in one of the things. In modified RMI, it was the cutoff was 120, and slightly it was like the U feature was a little changed, wherein if it was less than one feature, it was 1, and if 2 or more features, it was 4. And menopausal status, they gave a score of 4, so there they kept a cutoff of 120. Next slide, please. So if you see one of the examples wherein how RMI helped, one of the studies, quite an old study though, but it was a study which said that when the RMI score was less than 25, about 40% of women who belonged to that category in that trial, and the risk of cancer was less than 3%. Whereas the RMI was 25 to 250, the risk of cancer was about 20%. When the RMI is more than 250, the risk of cancer was 75%. So this is what the RMI suggested. So yeah, we can use it at times when the resource deficient settings. Next, please. So HE4, I'm sure like many of you would be knowing about it. So sensitivity of CA125 and HE4 was pretty increased. It went up to 83%, and specificity also was about 91% when HE4 individually was done. So when combined, it gives us a good information. And a normal HE4 level ruled out invasive cancer in 98% of women. So that's a wonderful specificity with an elevated CA125. So it offers superior specificity, as I said, in differentiating benign and malignant adnexal masses in premenopausal women. So yes, that's about HE4. So we include both and give a ROMA, that is risk of malignancy algorithm. So next slide, please. Yeah, so I haven't specifically mentioned. So Roma combines CA125 and HE4, and it gives us. So imaging, yes, I'm not going to talk anything much about imaging. Dr. Lohit has already told just one slide wherein if there's an adnexal mass, you see three major things. Either it is fully cystic, or if it is complex cystic, or if it is solid. So if it is solid, you see either if it is homogeneous or heterogeneous. If it's homogeneous, it is fluid usually. If it's heterogeneous, fibrous tissue as fibromathecomas or Brenner tumors. Where if it is purely cystic, again, if it's unilocular, multilocular, there are various things already. I'm speaking very basically, but it's something in the first level that a gynecologist, when doing ultrasound, should be looking at. So the most important thing, if you see, is the complex cystic, which is in between, whereas there is both a solid and a liquid. I mean to say solid component and as well as the cystic component, and more than that, nodules, vegetations, thick septations, all those things. So, yeah. So very important is the papillary vegetations and solid components. These are the two things which are very important apart from the septations. Next slide, please. So yes, after all these things, now we have seen the imaging, we've looked at the markers, and of course we've asked the good family history. So now, how do we proceed when an asymptomatic ovarian cystic mass is detected incidentally? Next slide, please. So asymptomatic woman, we look at the morphology to see the ultrasound, Doppler evaluation. If it's a benign cyst, we follow up generally, or sometimes we may do surgery if it's too high. I mean, if it's too big, sorry, more than 10 centimeters, especially, or an ultrasound if it's suspicious or has questionable findings. Then we also correlate it with CA125 or other markers like Roma, and we also do an MRI. MRI gives us a great information, and we may end up doing a laparoscopy. Whereas if it's a cancer, definitely, I mean, it's obvious if cancer, it's a cancer-specific treatment. Surgery would have to be done. Next slide, please. So the finding of an ovarian cyst in a postmenopausal woman raises two questions. First, what is the most appropriate management? And second, where should this management take place? Next, please. As the risk of malignancy increases, the appropriate location for management also changes. So that while a gynecologist might manage women with a low risk of malignancy, like the ORADs 1, 2, sometimes 3, sometimes not 3, and 3 and above. So yeah, those at intermediate risk and high risk should be managed by a GYN oncologist always at a cancer center, preferably, or at a center where all the operative facilities are available. Next slide, please. So when do you, next slide, yeah. So no, next slide. I had already, Dr. Lohit is speaking beautifully about it. So when to refer to the gynecological oncologist? Next slide, please. So the Society of Gynecological Oncologists and ACOG has clear-cut guidelines in premenopausal women. When the CA125 is more than 200, number one. Number two is presence of ascites. Number three is evidence of intraperitoneal distant mets based on examination or imaging studies. Family history, first degree relative. We have a question, what is the role of other tumor markers? We will be getting back to you on that. So yeah, and also the family history, whenever there's a first degree relative of breast or ovarian cancer, when these are there, that means that the referral should be done. And postmenopausal, by and large, all the same features except that elevated CA125 level, generally more than 35. So now you may ask, like, so in premenopausal less than 200, can we safely take? But again, you have to see all the other features as well. So that's how it is, because in borderline tumor, sometimes the tumor markers may not be elevated significantly. So that's the reason you have to, whenever there are suspicious findings on imaging, and even if the tumor marker is low, you got to talk to your radiologist, or sometimes to be very honest with you, every single case of mine, wherever it is done, more than 90% of my images, I discuss with the radiologist, not just telephonically. Many a time I also go to that lab, I see the images, or I get the CD and I see that here, and Dr. Lohit helps me, or whoever radiologist I have helps me in, I personally see the images. So that's very important. Please make it a practice and discuss with the radiologist. It's very important. And yeah, next slide. So postmenopausal patients also, by and large, the same thing. So management of ovarian cysts, conservative management, we all know that simple unilocular ovarian cysts less than 5 centimeter, having a low risk of malignancy. We can always manage them conservatively, especially in the presence of normal CA125, which will be normal most of the times. Next slide, please. The risk of malignancy in cysts that are less than 5 centimeter, unilateral, unilocular, and echo-free with no solid parts or papillary is less than 1%. So that's the reason. In addition, more than 50% of the cysts will resolve spontaneously within 3 months. As all of us know, as GYN gynecologists, we prescribe OCPs sometimes, and or we observe, and the next scan you do on a follow-up, the cyst may not be there. So it's safe to manage these cysts conservatively. The follow-up ultrasound scan for cysts of 2 to 5 centimeter, a reasonable interval being 3 to 6 months. Next slide, please. Cytological examination of ovarian cyst fluid is very poor at distinguishing between benign and malignant tumors, with sensitivities in most studies of around 25%. See, the very important point why I have added this slide is because many a times, certain times when the imaging is not very conclusive and the gynecologist operates and when there's a cyst already, do a laparoscopy. Sometimes they puncture the cyst, they take out the fluid, they see they're not very sure like what it could be, so they send it for the cytology. So always remember, cyst wall cytology, cyst fluid cytology is very, very low, and there's no point. We don't do it as such. So uh, before rupturing, before puncturing the cyst, be sure of what the other features are. We have had extensive discussion in today's imaging, so that's most important before puncturing the cyst. So that's very important. And also, I've seen some places in tier 2 cities and all, like not that in tier 1 it may happen, but what I've seen in my experience is like certain times they suspicious mass, they puncture the cyst, they take out the send for cytology, it's negative, and then the surgeon goes and does. No, that's not how you do it. Cyst rupture is highly unfavorable on the impact of disease-free survival. A young girl thinking it is, and if improperly evaluated preoperatively, imaging-wise, just go in and do a surgery after cyst fluid is negative, they will have a very bad. A girl who was not supposed to get chemotherapy will now have to get a chemotherapy because of the iatrogenic cyst puncture. So aspiration is not recommended for management of ovarian cysts in postmenopausal women. And also, even just because it's a big cyst, no point in decompressing it by aspirating it. No, that's also not a practice that has to be done. So I'm sure like it's quite clear. Next slide, please. So less than 10 centimeters cystic mobile unilateral cyst with no ascites. Generally, it disappears or becomes smaller. So you can follow up if it disappears or becomes smaller. Observe for 4 to 6 weeks. If mass persists, then of course we may end up in surgical exploration, especially if she's symptomatic. And anything above 10 centimeter, you go operate, or if there's a solid component, you operate. You got to operate a fixed. If there's mobilities is not good. And if there's bilateral, yes. And if there's ascites, yes, we do again go in for surgical exploration most of the times. Next slide, please. So indications for surgery in an adnexal mass, ovarian cystic structure more than 5 centimeter that has been observed for 6 to 8 weeks without regression. Any solid ovarian lesion, number 2. Number 3, any ovarian lesion with papillary vegetations in the cyst wall. Number 4, any adnexal mass more than 10 centimeter in diameter. Number 5, if there's ascites. Again, if there's ascites, it's very important not just to go and operate, because if there's ascites, that's an indicator, especially one of the indicators of advanced ovarian cancer. So you got to have a better imaging and rule out if there's advanced disease, and only then. So it's not that ascites, if it's there, she's going to go for surgery. No, she has to be evaluated by a GYN oncologist. And next point is palpable adnexal mass in a premenarchal or postmenopausal patient. Again, is something which has to be operated in whenever there is torsion or rupture, for which most of us gynecologists we do. We end up doing it. But again, there also, that is one kind of a gray area wherein, especially if it's torched, then the imaging findings may not throw too much of light, especially with Doppler showing absent flow. If there are certain solid elements and all, may not be appreciated well, but that's a different kind of a risk. So we will have to explain to the patient about this is what has happened, and we may have to, evaluate the mass and then think of a resurgery. That's anyhow a very small percentage, so I wouldn't go in depth into it. Next slide, please. So I wouldn't discuss too much about the ovarian cancer staging. Next slide, please. I'll just tell the important changes that have been made. Earlier, 1C has now become 1C1, 1C2, and 1C3, wherein 1C, 1A, 1B essentially is unchanged. 1C1 is surgical spill. 1C2 is capsule rupture before surgery or tumor on the ovarian surface, and 1C3 is the presence of malignant cells in the ascites or peritoneal washings, what we obtain during surgery. So this is what it is. So as much as possible, you need to avoid surgical spill, because anything in 1C will require chemotherapy. And no puncturing, because that automatically becomes 1C2. Next slide, please. So earlier 2C was there in old classification, which is no more there in new classification, which was positive washings. That has already come to 1C3. Next slide. So I wouldn't go too much into the previous one, please. Sorry. Yeah, 3A, 3B, and 3C are quite kind of, has become more subclassified, wherein 3A becomes 3A1, 3A2, and 3A1 1 again, 3A1, 3A1, 2. It becomes like that, wherein it depends on the size of the metastasis of the lymph nodes, mainly if lymph nodal, especially like when we do in early adnexal mass, suspicious, highly suspicious of malignancy, when we do a complete surgery, a complete retroperitoneal lymph node dissection, along with omentectomy as well as peritoneal biopsies. So when we do and when we see the final size of the lymph node, the pathologist also has to mention the size, what was the maximum size of the lymph node involved. So because that will again stage into 3A1 or 3A2, and 3A2 is again microscopic extrapelvic above the pelvic brim, and positive retroperitoneal lymph nodes. So there, again, there have been a lot of sub-classifications. I'm sure like we will forget it. We always have to, after the final histopathology is there, the final staging is given then rather than before. Next slide, please. And if you see the stage 4 may, it has again been classified into 4A and 4B, because pleural effusion with positive cytology becomes 4A, and 4B is anything like hepatic or splenic parenchymal metastasis. As Dr. Lohit already said, that parenchymal metastasis is something which becomes 4B, but anything surface metastasis, usually peritoneal cancers, including ovarian cancer, is generally on the surface. That is, we have the general peritoneum, that is the peritoneum that lines the entire abdominal cavity, and the visceral peritoneum that lines every single organ of the abdominal cavity. So every single organ is lined by visceral peritoneum. So when the disease sits over it, it's a visceral metastasis, which is still a superficial metastasis, and still it is operable, and it comes to stage 3C, where it's not 4B. So the very important and most important thing, another recommendation in the current staging is that histological type, including the grading, should be designated at staging. Many of the times the pathologist misses out on that, especially the serous carcinomas. They just write serous cystadenocarcinoma. No, you got to tell whether it's a high grade or a low grade. That's very important. And even in other subtypes like endometrioid adenocarcinomas, the staging is not mentioned, which is very important. And the primary site is again very important, wherein we got to tell whether it's ovarian primary or fallopian tube primary or peritoneal primary should be designed whenever it's possible, because again, although the management wise there's no much change, because both will include 6 cycles of chemotherapy, platinum based chemotherapy, and surgery. All the 3 cancers will have, but it's very important to stage, because there are minor changes, the minor prognostic changes that can happen. And tumors, adhesions also something are very important. Adhesions also should be during the surgery, which I'll be speaking about a little later in the surgical part, also should be commented about. Next slide, please. So coming to cytoreductive surgery, I'm not speaking much about the early surgery. As I told you, early surgery, all of you know, that is removal of the, if it's family completed, we're going to do something called as a primary cytoreductive surgery, wherein we're going to remove the ovarian tumors, and if frozen, if it comes out as malignant, we're going to go remove the uterus, remove the other ovarian tube as well, and take off the infracolic omentum. Although there's no clear-cut differentiation between infracolic and supracolic many a times, especially if the omentum is shrunken. So yeah, you got to do omentectomy has to be done, and lymph nodes, pelvic, both the pelvic as well as the para-aortic lymph nodes have to be done, and just below the renal vessels. So many a time I see, sorry to say, very rarely I've even seen with some oncosurgeons also, only the pelvic lymph nodes are sampled. No, retroperitoneal, that is the para-aortic, even supramesenteric lymph nodes, not just below the inframesenteric level, properly till the renal vessel. So that is where the actual sentinel lymph node of ovary is there. So you got to do a thorough lymph node staging. So that's very important. So that's for early. Yes, we either do it either on an upfront or an interval basis. That is, we do it. This is mainly for the advanced ones. What I'm speaking. We take a call. This is the decision which the gynecological oncologist takes in conjunction with the radiologist, as well as based on the histological. Based on the peritoneal carcinomatosis index, everything on the radiological part, what we earlier discussed. So based on this, we take a call which is operable upfront, which is not operable upfront. If it is not operable upfront due to specified reasons, you got to mention those reasons. Then you got to take a biopsy, do a neoadjuvant chemotherapy, and then do interval surgery. So that is called as interval cytoreductive. So either CRS can be upfront or interval. So case selection is very, very important, as inadequate preoperative assessment of the disease followed by suboptimal surgery has the worst prognosis. So never ever venture if you have not made a proper radiological assessment and an assessment. So this assessment, generally the gynecologist will have to always involve the GYN oncologist, especially if it's high risk. Next slide, please. So, what are the criteria for neoadjuvant chemotherapy? Radiologically extensive. When there is extensive carcinomatosis, when there's heavy mesenteric disease, when there is large plaque-like thick diaphragmatic deposits, epiphrenic nodes, that is presence of the supradiaphragmatic lymph nodes, high volume disease in the pouch of Douglas, like sheet-like disease, also in the root of the mesentery, or in the lesser sac disease, or in the lesser omental disease, disease near the celiac plexus. So, there are multiple sites which we call as the danger sites. So when these sites are involved, it is not at all worth to go in for upfront surgery. And also, when it comes to the performance status of the patient, when there's poor medical condition, multiple comorbidities, then other surgical better not do a upfront surgery. Go for a neoadjuvant chemotherapy, because the goal of debulking, we call now the debulking word is also replaced by cytoreductive surgery. The goal of cytoreductive surgery is to leave behind no macroscopic residual disease at all. So that is the goal. Next slide, please. So only role of obtaining a biopsy, as I already told, is case of extensive carcinomatosis proven clinically and radiologically to get a tissue diagnosis before initiation of neoadjuvant chemotherapy. Next slide, please. So surgery, next slide. Next slide, next slide. Yeah. So as Dr. Lohit has already shown you the picture of peritoneal carcinomatosis index, just like what they do, the radiologists, that is either the CT PCI, there is a CT scan PCI, or the MR PCI. Okay. The same way, in surgically, we do something called as the surgical PCI. Actually, it was the surgical PCI that was first designed by Dr. Paul Sugarbaker, the father of cytoreductive surgery. The abdomen is divided into quadrants. Whatever disease you see, you gotta make a lesion score size and the location, and you gotta give a scoring. Finally, from 0 to 39, the score is there. Based on all, it's already been discussed, the same thing. So you do a PCI, and then we have to score it. Next slide, please. So comprehensive, what does the staging laparotomy for suspected ovarian cancer? We already told you got to do a midline vertical incision. Yes, coming to, I will just digress slightly here in terms of when do you do a laparoscopic staging? Again, one of the major multicentric trials, a French study showed that tumors more than 10 centimeters, better not to do a laparoscopic surgery, but less than 10 centimeters with absolutely no disease, wonderful reporting of imaging showing no disease elsewhere. And also, when you put in a scope and see if there's no disease in the peritoneum and if there's a suspicious mass, you can do. But again, you've got to be trained so that you won't rupture the tumor intraoperatively, number one. And number two is, yeah, as the cyst size increases, as the cyst shape differs, it's very difficult to put it inside the endobag as well. So there's no point. In my practice, I would say, yeah, 5-6 centimeters max, or kind of a vertically elongated, something like that. I would go for it. And if it's purely cystic, the chances of rupture, because you're not touching the cyst with instrumental spillage, is very high. So I'm not very happy about doing. So instead, when it is high chances of malignancy, ORADs 4 and 5, I would rather open, because I will also have to do a complete para-aortic as well as pelvic lymph node dissection. Again, that can be done laparoscopically, but the duration of surgery may increase, and sometimes we may not feel the peritoneal surfaces, we may not see all the peritoneal surfaces. So that's the reason, as of now, we have to do a open surgery, so midline vertical incision. Of course, for young girls, I try to close it more cosmetically, wherein we try to use subcuticular stitches. It's a laborious process though, and sometimes I use different mechanisms to kind of give a better scar. But yes, no surgical, oncological compromise. Next is obtain peritoneal washings, inspection and palpation of all peritoneal mesenteric surfaces, biopsy of any lesions or adhesions. Doing a THBSO plus infracollicumentectomy plus RPLND for all those women who have completed families, but for select women who are very keen on fertility, only when the gynecological oncologist presents, and in his or her presence, and after appropriate assessment of the tumor markers and imaging, only then, after proper counseling, we do a fertility sparing surgery. Borderline tumors, most of the times fertility sparing surgery. Germ cell tumors, always fertility sparing surgeries. Granulosa cell tumors, younger, I'm speaking of younger girls, again fertility sparing surgery. So it is that the call is taken. by the GYN oncologist in conjunction with. That's very important. And of course, we also obtain some random peritoneal biopsies. Next slide, please. So you can see just few pictures. This is one of the early cancers on the right. Adnexal mass was there. Did a midline incision. And next slide, please. So yeah, if the bubble was all adherent, so technically, those adhesions also have to be removed. So next slide, please. Yeah, it was the bubble was separated from the tumor. Next slide, please. But since it was a superficial kind of an adhesion, I did not have to literally do a bubble resection because it was more of an abutment adhesion rather than an infiltrative adhesion. So if you can see here, I shaved off the serosa at multiple places and took seromuscular stitches, and I didn't have to do a small bubble resection. Next slide, please. Yeah, and there was also certain suspicious peritoneum in the anterior parietal peritoneum, so that also have excised. If you can see that the raw area. Yeah, next slide, please. So this was the removed peritoneum. We call it a selective field peritonectomies. So when we do just only the involved field peritonectomy, rather. Next slide, please. So yeah, this is again when I'm doing the right subdiaphragmatic peritonectomy, whereas usually the common site of peritoneal disease when is there, we tend to remove that. Next slide, please. So yeah, this is again the diaphragmatic peritoneal stripping. So generally when it's miliary deposits or something like that is there, we got to remove the entire diaphragmatic stripping peritoneum. We have to remove. Next slide, please. So in advanced ovarian cancer, again, the same thing, complete resection of all macroscopic disease, including peritonectomy. Sometimes we may end up doing bowel resection, anastomosis, appendectomy, splenectomy, segmental tuber resection. In achieving optimal debulking, you don't leave it. You just go there out, full out, and remove whatever macroscopically your disease. Because the most important is optimal debulking. And whenever there's unresectable disease, again, it's not a good sign of not seeing it or not getting surprises. So surprises, intraoperative surprises are very, very bad, as Dr. Prerna said initially, that it's the role of a radiologist is very important to to minimize the surprises, intraoperative surprises. And of course, sometimes we also do intraperitoneal chemotherapy or HIPEC. Next slide, please. So newer concepts, please, next slide. Yeah, this is something which we need to know. So earlier we used to tell optimal debulking. Even now, many of the surgical oncologists tell optimal debulking R0 resection. R0 resection is less than 1 centimeter of tumor. Even if it is left behind, it is adequate. So now it's not adequate. No, we call it as a CC score or a completeness of cytoreduction score. That is the score we give, and see that when there's no peritoneal seedling left in the operative field, it is CC0. So your aim should be to achieve a CC0 or maximum CC1, wherein there was certain disease removing which could have endangered the patient's life in terms of, like, say, for example, disease is there on the porta hepatis, so it's quite close to the portal vein, or it's posteriorly behind the liver. If it's close to the IVC, removing it could have kind of made a nick on the IVC. There's too much of exsanguination, or like you may have to call in a vascular surgeon at that point of time to suture that place. Generally, the rest of the IVC, we tend to do it, but in complicated situations, places, it's very difficult to vein retracts. So that's the reason in such situation, if you're even leaving behind a disease, leave it only less than 2.5 millimeters. That's it. You shouldn't be, I mean, if you're leaving behind more, sometimes that happens, but if you're leaving behind more, it means that that's not an optimal surgery. So that's how it is. So that is so CC2 is more than anything more than 2.5 millimeter at a CC2. CC3 is if you're leaving behind a confluence of disease or unresectable tumor, it's CC3. So you have to mention the CC score in every surgery. That's very important. Next, please. So there's also something called as prior surgical score. Depends on the prior resection done before a definitive site reduction. Sometimes the primary surgeon, be it the gynecologist or the general surgeon, would have done. They do a surgery, say by a transverse incision or a paramedian incision. In earlier days, they used to do something like that when they do, and they send to you. There is we also have to calculate something called as PSS. That is, when there was no prior surgery or only a biopsy was performed, it becomes a PSS 0. When only one region was addressed with prior surgery, it was PSS 1. It's 2 to 5 regions were addressed previously dissected, PSS 2, and more than 5 regions of previously, it's PSS 3. So these are all the newer concepts. We peritoneal surgeons generally like to have this information. Next slide, please. Next slide. Yeah. So coming to HIPAC. So very important is the cytoreductive surgery. HIPAC is not the magic. Cytoreductive surgery is the magic. And because doing a cytoreductive surgery itself is so important, wherein you got to remove the entire parietal peritoneum. So there are a lot of newer concepts now, like when I do the parietal, total parietal peritonectomy, wherein we remove the entire peritoneum. I'll be showing you some of the images, and we remove like that, and we divide into right upper quadrant peritoneum, left upper quadrantectomy, total pelvic parietal peritonectomy. I'll show you some images. So that's how we have to do it. Only then, if you have achieved a complete cytoreduction score of CC 0 or 1 max, only then you are eligible, you are legally okay to give a HIPAC. So what does HIPAC do? As all of you know, it is like hyperthermic intraperitoneal chemotherapy, where the chemotherapy drug is heated up to a certain higher temperature, generally up to about 44 degrees centigrade in the machine. We generally use a separate machine for that. There are various machines, and in that, the machine is dedicated for HIPAC. And once it comes down, so we have to ensure that the temperature is about steady temperature of about 42 to 45, 42.5 degrees centigrade. There's a steady temperature inside the peritoneal cavity. There are two inlets, there are two outlets. So wherein that goes to the machine, and there's a reservoir in the machine. So there's no air gap anytime in between. So there are different techniques. There is two techniques, open and closed, which I'll show you the pictures. So I used to do open earlier. Now I do the closed. I'll show you the pictures. So wherein about for 60 minutes to 90 minutes, we circulate the peritoneal lavage is being done, wherein there's a recirculation of fluid happening, because of which the microscopic disease that have escaped the onslaught of surgery will be killed, or that's the concept. So HIPAC does help. Usually we use cisplatin. That's the commonest drug that we use. Rarely we also use doxorubicin in recurrent cancers. Next slide, please. So this is how it goes. Next slide. So this was the open technique that I used to do earlier, wherein the entire, like, we used to lift up the abdominal edges, the skin edges, and we used to see that the chemotherapeutic fluid used to kind of be there, covering till the rectus sheath. I mean to say, till that time. And sometimes we used to use a wooden spatula, like kind of baking noodles. That's how it used to be called initially. So this is how my initial training, before my official training, this is how I stood. And this is also approved even now. Many countries do practice this, both closed and open. Even in India, certain people still practice this. Next slide, please. So next slide. Yeah, so this is where, like I told you, the baking noodles or whatever. Next slide, please. We have a dedicated retractor. So if you see in this picture, I have just left it, closed. This is a closed technique, wherein we completely tentatively close the skin, and the inlets, outlets are there, and we just stand out, we take a break, we have a coffee. So the machine is taking care of the recirculation part, and this is what we do. Next slide, please. So we have dedicated retractor, Thompson's retractor, or sometimes book Walter. You can see the machine here on the right side. So that's the machine with a plastic bag beneath. That's a reservoir. So next slide, please. So everything is aseptic precautions. Yeah, this is the closed technique. Again, same picture. Next slide. Yeah, this is how it looks like. If you can just enlarge and see the skin, there's no completely, everything is closed, and we generally keep these pads around so that there's no spillage. If there's spillage, you got to take another bite and close the skin. Next slide, please. Yeah. So we are all waiting like for that 60 minutes to end. And if you see below my leg, there's also that, disposable mattresses are all placed. I mean to say, sheets are all placed, wherein if there's by any chance spillage, these are all the standard things that we take care during. There are SOPs that when we do a HIPAC. Next slide, please. Yeah, so these are the common drug that we use is cisplatin. Next slide. Yeah, this is the machine. just brief view, and it also gives us a graphical thing, and everything is digital. So it gives us the temperature exact side, whether there's a temperature probes are there, which gives us. Next slide. Yeah, this is what it gives the temperature. It tells us how much of the peritoneal dialysate fluid has gone in. Yeah, I'm sorry, I forgot to tell that. We put the chemotherapy in a peritoneal dialysate solution, either PD solution or sometimes even saline. So in this, that is the carrier solution, what we call. So we use that, and it gives us how much of fluid is inside. And next slide, please. So we can't use too less of a fluid. We can't use too much of a fluid. So it depends. Like that's the calculation that we do based on each body surface area. Next slide, please. So we write that HIPEC in progress, and not many people keep coming and entering out. So all the next slide, please. So all the disposables are all circulated. I mean, sorry, they're all disposed in a separate cytotoxic waste. Next slide, please. So it's all a teamwork. This is basically to show that it's a complete teamwork. Next slide, please. So yeah, this is all about HIPEC, and there's something called as PIPAC also, which is a pressurized intraperitoneal aerosolized chemotherapy, usually in recurrent ovarian cancers and platinum-resistant ovarian cancers. It's basically a simple laparoscopic procedure, and the chemotherapeutic drug is administered through an angioinjector at high pressure, wherein we convert the liquid form of chemotherapy to aerosol by a dedicated instrument, which is a pen-like instrument put through one of the lab ports. There's a wonderful absorption and penetrability, and it's a repeatable procedure, and mainly aimed at improving the quality of life in those women with recurrent cancers who have failed multiple lines of chemotherapy. Next slide, please. So this is how. Next slide. Next slide. Yeah, next slide. Next slide. Just to show a few pictures, so you can see completed paraortic nodal mass. I know may not be very classically seen. Where the devas retractor end is there, you can see that the retroperitoneal vessels, the aorta and the IVC are all totally exposed. In fact, here the IVC also had the lymph node was tethered. I removed it and had to suture the IVC at a couple of places. So yeah, that's how totally it becomes totally naked. You can see all the vessels. Next slide, please. In the left side of the picture, the disease is densely adherent to the diaphragm. So that's the reason it's becoming difficult for us to remove. But then, yes, we have to sometimes even shave off a part of the diaphragm also. That's how we do. And if on the right side, you can see there was a liver surface lesion that was removed, and bed has to be fulgurated. And this is how it looks like. Next slide. Yeah, so here where if you can see that the skin edge, the rectus sheath, the Alice is catching the rectus sheath edges, and in the other side, the other Alice is catching the edge of the peritoneum and trying to separate the parietal peritoneum, not opening the peritoneal cavity. So we create a plane like that. And the second also we are doing, wherein I have completed the parietal peritonectomy in the anterior aspect. So we extend it to the lateral aspect as well, and upper like the diaphragm on both sides, and the paracolligators in the middle aspect, and lower down the bladder and ureters you lateralize. So that's how we do. Next slide, please. So this is the total parietal peritonectomy. Yeah, so here you can see the mobilization of the subdiaphragmatic peritoneum. Next slide. So we need wonderful retractors for this. So here you can see this is the right lower quadrantectomy. As we came down, there was a lot of disease on the right side, and the bowel part, you can see the appendix also was involved, and whatever disease was there. So along with whatever I'm holding with my the fingers, you see on the lower side is my right hand, and the left side is the left hand. So just lifting up the peritoneum and showing wherein so much of disease is involved. Of course, if you go deeply, you can see more. If we can also see the ureters being lateralized on one of the things. Next slide, please. Next slide, please. Yeah, so this will be the specimen, once the total parietal pelvic peritonectomy with tumor with resected rectosigmoid segment. In this case, since there was also adherence to the rectum, we have to remove a portion of the rectum as well. So you basically do the parietal peritonectomy, come down. I mean, laterally you lateralize the ureters, the vessels, and anteriorly you lateralize the bladder and come down and go till the vagina, cut the vagina, lift up the posterior vagina, create the rectoseptum, the rectovaginal septum there, and you come out. If it's a long segment thing, you cut the rectum also and finally get it out. And if you can see that the tumor is there in the upper aspect, and the rectum is there on the left upper aspect, the rectum with the appendices epiploicae, and the rest of all is the peritoneum. Next slide, please. It actually looks small. It's a huge one. Same specimen from the other angle. Next slide, please. So this is another total pelvic peritonectomy specimen without rectal resection. So here she did not have a rectal disease of much, so I could shave it off easily. So this is how it looks. I mean, if you stretch, it's all kind of rolled. The edges are rolled. If you open it, it'll become even bigger. Next slide, please. Yeah, another angle. Next slide, please. So that's the cervix being held. This is again the tumor. This was a low-grade serous tumor with limited PCI, but extensively infiltrative disease in the pelvis. So we had a lot of work to do in the pelvis. Next slide, please. This is another limited peritoneum en bloc removal of tumor with segmental rectal resection, a post-hysterectomy lady. So here also you can see lower down on the 4 o'clock position of the image, the rectum is there, which is all adherent to the tumor. So the tumor was adherent. So this is how we remove completely. Next slide, please. Yeah, here this is a total omentectomy with spleen along with the primary tumor. So the primary tumor is beneath. Above what you can see is a total omentectomy with the spleen. So remove the entire omentum along with the spleen as one single specimen. Next slide, please. Yeah, it can infiltrate multiple segments of bubble. Again, we may end up doing multivisual resections there and anastomosis as well. Next slide, please. Again, various pictures of parietal peritonectomy. I told you that we are going to strip off like multiple places. We keep stripping off the peritoneum. This is the anterior parietal peritonectomy resection. Next slide, please. So yeah, this is all about like various pictures what we showed. Like I mean, cytoreductive surgery involves a heavy, it's a commitment. It's basically like I keep telling my patients that, or first and foremost, I've told myself. Next is I tell my patients and my team that it's like we are going for a war. You are not going to remove any single infiltrator or terrorist. I mean, you're going to go to the last person, kill him and come. So that's the intent with which you got to go for a cytoreductive surgery. If not, they will not survive longer. And that's the reason, by God's grace, we keep seeing very good results with extensive surgery, dedicated surgery. So it's a teamwork as well. You got to have a wonderful anesthetist. You got to have wonderful team people, the nurses, everything. It needs to be very organized. So yeah, this is all about the surgical aspect. And of course, post-surgery, as all of you know, the adjuvant therapy is platinum-based 6 cycles. Follow-up will be every 3 months for the first 2 years, 6 months for the next 2 years, yearly thereafter with clinical examination, imaging, and CM125. And yes, when recurrence is suspected, we go for second line chemotherapy or anything. Next slide, please. Or some rarely PIPAC as well when the chemo lines are failed. Next slide, please. So yeah, next slide. Same thing about PIPAC. So this is how PIPAC. Sorry, one slide before. I'm sorry. Yeah, if you can see there, the angio injector is there, and there's a pen-like instrument which we call the PIPAC pen, and the camera. Everything is fixed, and when we are doing PIPAC, nobody should be there in the operation theater, including the anesthetist. Everybody is out. We have the monitor that we are seeing from outside, and it's just about a half an hour procedure. We use 2 drugs. We do it with 2 injectors, and it beautifully forms wonderful aerosols. And after all that, one drug is done, the another drug is done, then we go in. So this is just briefly about PIPAC. Next slide, please. So there are normal drug molecules, very important, that the PARP inhibitors have actually the ones which have also become game changers now. We do the tumor, whatever we've removed, we subject that to homologous recombinant deficiency testing, the genetic testing, and we see if they are positive. We give them these PARP inhibitors for a minimum of 2 years, which were very expensive then, but which have come down in cost and significantly improved the survivals. We used to see 5-year survival. Speak of 5-year survival, we speak of 10-year survival also now in the advent of with the advent of all these inhibitors. And we also have something called as bevacizumab for those who are HRD negative. There's an anti-angiogenic inhibitor which decreases the blood supply to the tumor, and which is also given as a maintenance therapy. Both are given as maintenance therapies, and we see very good results with both, especially with PARP inhibitors. Next slide, please. Yeah, so future frontiers, there are multiple things. Actually, there's a latest novel sensor which I am developing. That's my own invention and have filed it for patent. And there is something called as ICG therapies also. HIFU is there. Molecular targeted immunotherapy is there. A lot of things. Next slide, please. A lot of things are coming up. So how to improve the quality of surgical management, appropriate surgeon skill and training, optimal infrastructure for delivery of high specialized care, and ability to accurately predict those likely to achieve surgical success, discussion in MDTs, good radiological knowledge, incorporation of algorithms, institutional as well as subsequent validations. Next slide, please. So yeah, all these things. We involve a lot of people. As I told you, it's a big teamwork. Next slide, please. Special scenarios. Yeah, I would like to run it fast as my phone battery is low and I don't have a charger. Anyways, yeah. Prepubescent girls, as I told you, any adnexal tumor more than 2 centimeters is significant, almost always a germ cell tumor. Fertility sparing surgery is the rule even in advanced disease. And fertility specialist consultation is also very important. Next slide, please. And yeah, postpubertal girls, again, it's a very sensitive age group, gonna correlate with a lot of tumor markers. Again, good imaging and fertility sparing surgery is the rule again. Next slide, please. Pregnant women, again, all of you know that first, second trimester is the best time to do surgery, even if in case. And you have to try to, properly have the proper indication of surgery, and only based on that, you gotta decide. And sometimes we also postpone it if it's a borderline tumor and stuff like that to third trimester, and we do an elective section and as well as a complete surgery for the tumor. Next slide, please. Advanced stage, if it is there, unfortunately, chemotherapy may have to be given after 20 weeks, followed by elective section. Early stage, complete staging can be still done, preferably second trimester. Next slide, please. So takeaways, 10 to 15% of cysts are malignant in the premenopausal groups. Predominant postmenopausal adnexal mass are malignant. Knowledge about right choice of imaging, very, very important. Choice of tumor markers, very, very important. RMI, decent indicator, mainly low resource settings. Oncological principles, never to be compromised. Advanced ovarian cancer, please have your gynecological oncologist, especially somebody who's trained in PSM, peripheral peritone surface malignancies. And a lot of encouraging survivals we see with optimum surgery and IP chemotherapy like EPIC, HIPEC, PIPAC, etc. Liaison with the light specialist, very important. GYN oncologist, radiologist, pathologist for the best evidence-based therapy. Next slide, please. So my journey briefly, please go ahead. Next slide, next slide. Yeah, this is my primary mentor, Dr. Marcello on the left side and Dr. Cusamoro on the right side from Italy, NCI Milan. Next slide, please. I was there about 2018 and 2023 twice. And left is Dr. Lana. She's one of the best surgeons I've ever seen. And Dr. Domenico in the center. My friends and on the right side from Barcelona. Next slide, please. My PIPAC training at Singapore. I was the first GYN oncologist in the world, in India to be done. Next slide, please. This was my official certificate. Next slide, please. Yeah, so this was my official certification of ESPSO fellowship. I was the first gynec oncologist in the world to be certified. So it's a great blessing. Thank you.
Thank you so much, sir. Your talk was extremely enlightening in terms of how to manage suspicious adnexal masses as well as how to deal with advanced ovarian cancers. And it was an in-depth approach. So there is only one question in the chat. I believe we can, we've already, it's almost 9 p.m. So the question may be addressed on the chat box itself. So I'm sure today's session was very helpful in guiding the OB-GYNs in how to manage the adnexal masses whom they see frequently in the OP clinic in terms of imaging as well as management. So I thank both the speakers, Dr. Lohit and Dr. Rupesh sir, for their insightful sessions. I thank Dr. Durgadas Asrana sir, President of Kasoga, for giving us this opportunity on behalf of the Preventive Oncology and Gynae Oncology Committee to conduct the webinar. Thank you, sir. I thank Dr. Shobha Gudi ma'am, Secretary General, and Honorable Treasurer and EC members of Kasoga for giving us this opportunity. Thank you all. Thank you to all the participants who were very cooperative in helping us maintain the etiquettes of